So some patients will have MDS that progresses to AML before receiving therapy. But the majority of patients with higher risk MDS that then go on to progress to AML have had prior hypomethylating agent therapy. And I think that this is a huge challenge for us in the field. When they have progressed to AML, there's no great standard of care for people who've had prior therapy on hypomethylating agent. There's a lot of strategies that are attempted. People may try an induction regimen. We know from multiple prior studies that patients who have had prior hypomethylating agent therapy for MDS do not have as good of a response to induction chemotherapy, either standard idarubicin cytarabine or variations of that, or even with Vyxeos, the subgroup that did not seem to do as well had prior HMA. Some will add an alternative agent to hypomethylating agent therapy. So you might add venetoclax, given the new diagnosis of AML. You may look at changing your hypomethylating agent backbone. You may look at low-dose cytarabine or another alternative, less intensive therapy. For some patients who are younger and can proceed to transplant, certain myeloablative conditioning regimens may also be considered. But there's this group of patients who've had prior MDS and then develop AML, who I think we're seeing more of as we're able to treat more patients with better supportive care and increasing the number of patients who are treated with hypomethylating agents. But at the transition to AML, it's really an area of need in the field. This is probably a group of patients that merits specific investigation to try to understand which targets, if any, might be options for therapeutic intervention, and also to try to understand, what should be the approach for the majority of these patients. So I hope that becomes kind of our area of focus as a field. It'd be great if we could avoid the progression altogether, but until that's here, I think looking at that group specifically remains important.